Welcome to the Eye on Annapolis Local Business Spotlight. There are thousands of locally owned businesses in the area, some small and some large. Some you may know and others you don't. But one thing they all have in common is a great story, and we want to share it with you. Join us every Saturday as we talk to the founders, the owners, and the managers of local businesses you have come to know and love, and those you will come to know and love. Now here's your host, John Frenay, with this week's Local Business Spotlight.
Joining us on the phone right now is Dr. Jason Taksey, who is a doctor with Maryland Oncology Hematology. How are you today?
I'm doing great. Thank you for having me.
Well, hey, thank you for calling. And one question for you right off the bat I got for you. You're part of Maryland Oncology Hematology. What is the difference? They're two words.
So oncology refers to management of cancer, and specifically we're medical oncologists, so we're the ones that give the medicines like chemotherapy. Hematology is broadly disorders of the blood, so that can include cancers like leukemia and lymphoma, but it can also include benign conditions like anemia or low white blood count or other blood count issues.
Okay. And you are based out of 810 Bestgate Road, which is that bright new big shiny building right on Bestgate Road with a new traffic signal out in front of it, right?
That's right, exactly.
It was for a while, it was going up. It's like, what's going up for there? What's going up for there? And it's really, really nice building. And your website is marylandoncology.com. And you guys obviously you're new to the building because the building was just completed probably 6 months ago. But is this a new practice in Maryland?
It's actually not. So Maryland Oncology Hematology has been around for a while. I actually don't know that I know the exact starting year, but over time the practice has increased. So we actually are the newest division. There are now 6 divisions, with us being the last one. There are other divisions in Silver Spring, in Southern Maryland, like the Clinton area, Frederick, as well as Rockville. So that there's 6 total divisions at this point in time.
When you talk about divisions, are those offices?
Well, so our division right now, we only have one office. Some of the divisions actually have multiple offices. Each division, to some extent, functions as an independent practice, but all 6 divisions come together, under one company, so to speak, and that allows us to achieve bigger goals like running clinical trials, having more lab resources, just in terms of being able to obtain and acquire the different medicines like chemotherapy. So, we have a common company together, but each division does function to some level independently of each other.
Okay. And how many people are in your division?
There's nine physicians in our division.
Oh, wow. Okay. So you guys have obviously the brain trust, if you will, as a patient's coming in. You've got 8 other people that you can rely on for consults and everything else as well as you're treating a patient, I imagine.
Absolutely. I mean, that's one of the important things in oncology is having other people to talk to. We do spend a lot of time talking with each other about patients just to, get ideas from each other, review data together, and just make sure that we have, a cohesive plan.
What is your background? I mean, how did you get into oncology?
So I was fortunate in that when I was an undergrad, I had the opportunity to do research at the National Cancer Institute, just as a way to gain experience. And, as I was starting my medical career before going to medical school. And so at that point in time, I really, became interested in the new science in oncology. I mean, that was the beginning of when things were changing quite a bit for the better. When I ended up going to medical school, I had that background already. And I found as I went through the different rotations that, clinically, it was also, I think, one of the most rewarding fields in addition to just being one of the most interesting.
Okay. Now, did you always want to be a doctor when you were like 12?
I did. Yeah. I remember when I was in 7th grade, we had to write a paper for English class about what we wanted to be when we grew up. And that's what I picked, was becoming a doctor.
And when did it turn into an oncologist for you?
So in terms of when did I choose to go?
Yeah. Was that after you did your research as an undergrad?
Yeah. I think that I started down that path when I was doing the research in undergrad. And then during your 3rd year of medical school is when you start doing clinical rotations where you actually get to see each field in practice. And so I think getting to see it really solidified my interest. And so as I started to apply for residencies into the 4th year of medical school, I went into internal medicine as a way to get into the oncology field.
Interesting. I've got a couple of friends that are doctors, and they've ended up in careers that totally weren't what they intended to, as far as, getting into the medicine business. I mean, I want to be the family doctor. I want to be a general practitioner, and somebody is now a plastic surgeon, and it's it's just totally different. It says, well, no, a bug got me, and I really, really like that.
Sometimes you fall into it and you don't know why.
Well, I guess that's, well, it's good. I mean, you've got the passion and something's driving you, and that's awesome there. Well, I'll tell you, and oncology is obviously, I mean, on the broader scope, you've got medicine. Oncology is obviously a specialized division or a specialized segment of the medical field. Within oncology, I mean, there are, and knocking on wood, I have not had to visit an oncologist, and I hope I never get to meet you in person anywhere other than over a beer someplace. But
I agree.
But I mean, are there subspecialties within oncology?
So yeah, I mean, so oncology really is divided into surgical oncology. Obviously those are the people that do operations. Radiation oncology is the group that does radiation, and then we're the medical oncologists. So we primarily are giving the different medications. And then within medical oncology, the data has really just expanded exponentially in terms of how to manage cancers. So really now within medical oncology, I think each oncologist is developing an interest in a smaller part of the field. So as an example, there are lots of medical oncologists who will treat primarily lung cancer. There are medical oncologists who will focus on breast cancer. I've followed an interest in urological cancers. And so as the field expands and treatments expand and we have more data, we each have to, I think, start to narrow our focus more and more to make sure that we have expertise in a manageable amount of the field, if that makes sense.
Yeah, no, it really does. And you mentioned, you said cancers with the plural there. In the basic sense, are all cancer? I mean, I realize that there's breast cancer, there's prostate cancer, there's lung cancer, there's brain, there's a zillion different cancers. But in the most basic sense, are cancers all the same?
So I would say that cancers are all really very different. In fact, we make the statement lung cancer, but one lung cancer is not the same as another. And that's really, I think, been where we've really been able to make advances in treatment. Cancers are the result of acquiring mutations over time. And with developing mutations, cells develop the ability to grow in an unregulated fashion. And so just through research, the field has been able to understand more and more which mutations lead to different cancers. And so, as an example, in lung cancer, one person may have a lung cancer that's driven by mutation in a gene called EGFR, and that gives us one type of therapies, whereas another patient may have mutations in a gene called ALK, just as an example, which gives us a different type of therapy. So, not only are not all cancers the same, but even the same organ, a cancer in the same organ can be different from one patient to the next.
Interesting. You're talking about the different mutations that are there. Now, are there cancers that go undetected, that are hidden, if you will? I mean, I obviously I know that I can go to my doctor, I can get a routine physical, and he finds a bump or something, in an X-ray or something like that looks a little suspicious, and that's how I would get to you, correct? Through a referral.
Correct.
And obviously, I can, select you is because somebody's told me that I need to see an oncologist. But
Right.
Is there any kind of a telltale symptom that you would suspect? I mean, I know, they say if you're having a heart attack, you got that radiating thing going down your arms and feels like an elephant sitting on your chest and stuff like that. But I mean, is there anything that cancer does that is common among all of them? It says, hey, this needs to be checked out.
So a lot of it is really based upon location. There are many cancers where there are proven screening tests that help us catch it early. So you think about mammogram for breast cancer, in particular in women. We think about the PSA blood test for prostate cancer in men, just as a couple of examples, or colonoscopy for colon cancer. So those are situations where there's a test out there that has been proven to catch the cancer early, when it may be asymptomatic, when it's perhaps at its most curable stage. Many other cancers don't have a screening test that's been proven. So you think about pancreatic cancer as an example. We really don't have a tool for that cancer where we know if we do a certain test like a CT scan, we don't really have data that tells us that we're going to catch it early. So then in those cases, it is based upon symptoms, as you mentioned. And then the symptoms that you would see really depend upon what kind of cancer is, what the location is. So just to use pancreatic cancer as an example, that may come with abdominal pain as a sign. Kidney cancers sometimes come with blood in the urine as a sign that something is wrong. Lung cancer may be chest pain or shortness of breath. So the symptoms that somebody would have really depend upon the location of the cancer.
But it sounds like the symptoms that you get for most of the cancers, I guess, then are fairly significant. I mean, it's not going to be just like, okay, I jokingly say, the worst thing you can do is when you're feeling bad is go to WebMD, because the next thing you know, you're going to be dying of some kind of disease that's, available, was eradicated in the 1400s in some country. It seems like, those are significant symptoms. All of a sudden I'm peeing and there's blood in the urine. I'm like, okay, hey,
right.
I need to get that looked at. It's just not that taco that I just ate. I mean, I'm really getting some stomach pains. That's your body giving you the warning sign.
Right. But what I would say is that most of the time, any random symptom that any of us can have is not cancer. So we all have to be careful not to, take a symptom and jump to the wrong conclusion. Most of the time, if you have abdominal pain, it's totally unrelated. Maybe it was something that you ate.
Right.
So what I would say is, first of all, we always should be up to date on our cancer screening. So, having a colonoscopy by the age of 50, for example, I think it's important to do that. So when there are proven screening tests, I highly recommend that we all follow through on them. With all these other symptoms that can sometimes be more subtle, I would say, we do have to be careful not to always jump to the worst case scenario when we have a symptom. But if there's a symptom that's just persistent, like let's say that, you develop a new pain in the abdomen and it's just not going away, then I think it's worth being evaluated. But if it's a symptom that happens just on one day, you ate something that you don't normally eat and then it goes away and doesn't come back, that's a situation where you just have to be careful not to assume the worst.
Cancer, I know, is very, very tricky. I mean, again, thankfully, my parents have both passed on, but neither of them were, with any type of a cancer. But my dad did have prostate cancer, and it was kind of interesting that they had went to treat that because they felt that was a little bit more advanced, but they discovered some bladder cancer. And this is secondhand. I didn't speak with the doctor that was treating him, but my father said the bladder cancer looked like it was like you took a handful of pepper and threw it against a wet paper towel. It was like a lot of little tiny lesions or spots.
Yeah.
But then when they treated the prostate cancer and they went back and they said, okay, fine, let's go back now and look at the bladder cancer, it was gone.
Yeah.
It was, and they figured that it might have been the treatment that they did for the prostate that may have gone at a lower dose or whatever it is and affected whatever was in the bladder. So it's really a difficult job to determine the course of action, I imagine, of what to do and how to treat.
Yeah, I mean, this is the challenging thing in cancer, is that, again, even in the same part of the body, the same cancer can be different from person to person. But I would say that we really have reached a point in cancer management where there's a lot of standardization. There are published guidelines that we all tend to follow. There's a guideline called the National Cooperative Cancer Network that we all tend to look at as we're doing treatment planning. There's also the American Society of Clinical Oncology that publishes guidelines. And really these guidelines allow oncologists, nationwide or even, throughout the world to really follow proven diagnostic techniques and proven treatments to have consistency, so that you're not getting a different plan just because you happen to go to a different part of the country.
Is there a cause for cancers? I mean, is this all a man-made type of thing? I mean, I know I've heard stories of, okay, there's some chemicals that get into the water and stuff like that, and there's a preponderance of cancers that it just reacts with the body and it develops into a cancer or something like that. Is it always some external force that triggers a cancer, or is it just something genetic or both?
So it can really be both. Really, if you think about, for me to perhaps oversimplify it, I mean, cancer is the result of mutations. And again, it has to be specific mutations that allow cells to grow in an unregulated fashion. So some people inherit an abnormal gene that starts the process where, as an example, there are genes called tumor suppressor genes that, roughly function to help prevent cancer development. So if you're born missing some of the, one part of a gene like that, and then you develop a mutation to lose the other part of a tumor suppressor gene, then that can help contribute to a cancer. So that's part of where you can inherit it. You can inherit a predisposition to cancers. But in other cases, it has to do with acquiring mutations over time. And that can sometimes be environmental. So we think about smoking as causing DNA damage, leading to mutations, and that's what contributes to cancers like lung cancer or even bladder cancer. You can think about UV radiation from the sun causing DNA damage in our skin that can lead to mutations to lead to different skin cancers. So really the answer is both. We can all be born with certain genes that predispose us to cancers, but then through different exposures throughout our lifetimes, we can also acquire mutations that contribute as well.
Interesting. Well, my mother actually was a 4 to 5 pack a day smoker for about 40 years. Which was, when she passed away and we were cleaning out our houses, what used to be white curtains were like a lovely shade of brown by the time they came down with all the nicotine that was out there. But it was hysterical in that when they examined her, she had no lung cancer. There was no lung issues with her. And she just quit in her, I'm thinking probably about 50, 55. And some doctor just, pardon the language, just scared the shit out of her. And she said, okay, I'm cold turkey. And she did quit cold turkey after that many years. And it was hysterical because it was mostly the smoking was all a crutch. I've got baby pictures of me with her like burping me and her cigarette in one hand and a drink in the other. But that was back in the 60s. But, she had a fake cigarette, a toy cigarette, which they can't sell anymore probably. But that was her crutch. She had it in between her fingers. And she would talk to you with the fake cigarette and everything else and pretend to puff on it. And for a while, and then she ultimately weaned herself off of it. But again, it was, whether it was a genetic thing, I guess, that would stave off that one, because you would think certainly with that type of smoking that there would be some damage in there.
Yeah, and that's actually, I think, an important point is, just because we are exposed to environmental factors like smoking that increase risk, it doesn't mean that it will cause a cancer. It's just increasing the risk. And there's probably a lot that we don't understand in terms of the body's own protective mechanisms to help correct mutations and reduce risk in the setting of an exposure like that. But again, just because we have an exposure doesn't mean that it's going to lead to a cancer down the road.
You said you did your undergrad up at UMD?
I did, yeah.
Are you a native Marylander?
I am, yeah. I ended up growing up and going to high school in Howard County. So been in Maryland my whole life for the most part.
Okay. What brought you to Annapolis and Arundel County? The job?
Yeah. So I ended up doing most of my medical training in Philadelphia. And so when I finished,
where in Philadelphia?
I was at Fox Chase Cancer Center.
Okay.
So when I finished, my wife and I wanted to be back close to family. And so knew we wanted to come back to the area. And yeah, I thought this was one of the best practices around. So I was excited to be able to be part of it.
Fantastic. Well, I'll tell you what, have we come close to curing cancer?
I think that's a great question. I think what I would say about that is we can cure a lot of cancers. You think about any early stage cancer, we can often cure. And that's pretty broad for all the different types of cancer out there. As cancers become more advanced, so you think about what we call metastatic or stage 4 cancer, we're still in a situation where when cancers become more widespread or advanced, we can't cure them, but we really have been able to control them for a dramatically longer amount of time than we used to. And so I think we're getting better at curing earlier stage cancers, but we're also getting a lot better at controlling more advanced cancers for a longer period of time and with less side effects from therapy. Our therapies are getting more targeted and easier to tolerate. Aside
from the, I guess, what you have to go through, whether it be, what in dealing with the cancer, what other suggestions do you have for cancer fighters and family members for, to coping with this? Because, I can't imagine there's a worse conversation than to sit down at the dinner table and say, hey, I was just at the doctor's and he says I've got cancer. And it could be just a fairly minor form of cancer, but it could also be something very serious. But I mean, what types of support do you recommend for people that are going through that?
I think family support is always the most important thing. Every so often I've, met someone or met a patient who doesn't want to discuss with family. But I find that can be very difficult because even if we tell someone that the prognosis is great, it still creates a lot of stress. So I think having family support, being able to have loved ones around to talk you through the concerns, maybe take you to treatments, I think that can be very important in terms of quality of life in really navigating the diagnosis. There are often support groups out there for different cancer types. So, there are usually breast cancer support groups where people with a common diagnosis can talk and, talk through their experiences and be there to support each other. So I think, looking at support groups, I think can be helpful because, in a tough situation, I think it's always helpful to have people who have gone through it and can share their advice. I think that can always be very helpful. And then, I think it's important that patients, talk to their oncologists. I find that sometimes my most helpful experiences with patients are those who write down their questions so that we can really look at everything and go through. Sometimes if someone is afraid to ask a question or doesn't write it down and they don't remember it, I think that can add to stress because they still have unanswered concerns. So I always certainly advise people to write down all of their questions so when they come to an appointment, we can really just run through everything that they're thinking and answer the questions and also help manage symptoms and side effects. Because again, if you write down those kind of things, then you won't forget them and we'll have the ability to address any of those concerns.
That's a great suggestion. I'm a guy that loves lists and check boxes and everything else. I mean, I would be totally doing that. I mean, we would figure out a couple hours to sit down and go over my list by the time we were done, done with this. But I know I've worked with the Wellness House of Annapolis a couple times with some different things, and they're a good resource for families and people that are fighting or and whatnot right down the road on Muscat Farms.
Yeah, absolutely.
But I guess one other question is how long is it going to be until you're unemployed? I mean,
yeah.
when are we going to do this? Is this going to happen in your lifetime?
Well, I think that I don't think it's likely that I'm going to be unemployed in my lifetime. I think really what's going to happen is we're going to take a diagnosis that historically has created a lot of fear into more of a diagnosis that is more like a chronic illness. I think that we're going to keep getting better at providing treatments that are well tolerated and very effective, so that even cancers in advanced stages, I think it'll become more likely that you can live with them, and I think over time they will become less life-threatening as again we learn more about how to treat cancer in a targeted way. So. Unfortunately, I don't know that we're going to completely eradicate it, within my time left working. But I do think that we're making substantial improvements in being able to make it a more like a chronic illness, if that makes sense.
Well, I think in medicine in general, we have really gone leaps and bounds over the years. And I mean, I would hope that it would be fairly soon that that we could find a cure for most cancers. I look at this COVID-19 thing where we've developed a vaccine in less than a year. Is pretty amazing. Back in the 1980s, if you were diagnosed with HIV, I mean that was a death sentence essentially.
Right.
And now it's not. I mean, there's just so many ways that we can treat that. I mean, and again, we'll go back into the 70s and the 80s. It was like, oh, your mom's got cancer, your dad's got cancer, your aunt's got cancer. That was it. Just a matter of when. And, now it's, you look at Governor Hogan who fought that and it's been in remission. You look at these women that are, diagnosed with breast cancer, some that have it in their genetics that they preemptively go for treatment and go for mastectomies just to, prevent it. I mean, there's a lot of options that are available to us now that weren't 10, 20, certainly 30 years ago. That's for sure.
Absolutely. I think HIV is actually a great example. We're not, in those who develop HIV, we're not curing it at this point. But we don't think about it in the same way as a life-threatening illness. Patients take their antiviral medications, and I think very often live a much better and longer quality of life than when it first came out. And that's what I think is likely to what's happening with cancer. As we learn more about mutations and develop more therapies to target those mutations in cancer patients, I think we're also turning it to more of a chronic illness that we can manage. And so I think that's the example where things are going.
Well, if anybody has, questions, I mean, I'm looking at your, not about us, but your team that you've got there. I mean, you've got some great talent, some, Harvard Medical. I mean, I see that you did a residency up at Temple up in Philadelphia with.
That's right.
So, I did my undergraduate up there. So
it's a great city.
It is. It's like Baltimore a lot that, it can get a really bad rap. But when you dig deep and you peel back the layers of the onions, there's some really great things that are about it.
Yeah, I agree.
It's kind of, except for that road from the airport into the city, that's just horrible. They should do something with that. That's the worst thing in the world. Welcome to Philadelphia. Here's the oil fields. But
that's true.
But that is what it is. But again, the website is MarylandOncology.com. You guys are located in the new building at 810 Bestgate Road, Suite 400, which is what, midway up on that thing, or are you up on the top floor?
We're the top floor.
Ooh, got the penthouse. Okay.
That's right.
nothing but the best.
We want to have the best view.
The best view on Bestgate, the best gate and the best view. Fantastic. Can people contact you just if they have questions, or would you prefer them to go their primary care physician?
No, actually, I think we're always happy to be there for any questions people may have. So, I think we're definitely open to talking with people if they want to reach out.
And just one thing, I didn't touch on this before, but as far as treatment goes, obviously you're in an office building, okay? I'm sure there's probably a mortgage company on the floor below you. So you are not, are you actually treating patients within your facility?
We are, yeah.
As far as the treatment goes, obviously you're seeing them and.
Yeah, so the way that most community oncology practices like ours work, we have space with exam rooms to see patients. We have a lab to do diagnostic testing, but then we also are giving our infusions in the same space. So it really is, just one location for everything. So most of our treatments are given in our office.
Okay. And then if there was a type of a cancer or something like that where there had to be, some type of surgery, then obviously you go to a hospital and you figure out, what's going on there at that point.
Yeah. We work, closely with our local surgical oncology colleagues and radiation oncology as well when those treatments are indicated. Fantastic.
Well, Dr. Jason Taksey from Maryland Oncology Hematology. I appreciate your time this afternoon, and thank you for educating me. These are the ones that I love, where I come in and I know nothing about it, and honestly, I hope I never get to know anything more deeply than what I've learned today from you. No offense, but what you're doing is just so critical and important to sit there and see that the leaps and bounds that we've taken in cancer treatment and steps to curing cancer. I think we live in a very great city, a great county that has this, and to have a practice that's, literally right here in our backyard is wonderful. And I love that you're fairly new to Annapolis, not you personally, but, the business, the practice is new, and, it sort of says something why you located here. So I think that goes a long way.
Thank you. I appreciate you having me on the show.
Thanks for listening to this week's Local Business Spotlight. Please make sure to visit eyeonannapolis.net for all your local news, events, and opinion. And in case you haven't already, please subscribe to the Eye on Annapolis Daily News Brief, where we bring you all the day's local news direct to your phone, tablet, or computer in about 10 minutes. It comes to you at 6 a.m. every Monday through Friday, and you can subscribe on Apple Podcasts, Google Podcasts, or wherever you get your podcasts.